Yep.
First question. Either in EMBARK study, both enzalutamide monotherapy and its combination with androgen deprivation therapy, they demonstrate a metastasis-free survival benefit compared to ADT alone. Additionally, parents who achieve a PSA level less than 0.2 ngml at week 36 were eligible for drug discontinuation. Given this finding, how do you devise an endocrine therapy plan for parents with biochemical recurrence in your clinical practice? Specifically, do you opt for monotherapy with non-hormonal therapy or a combination with ADT? And when do you consider discontinuation treatment?
So really great questions, kind of summarizing what we learned from EMBARK, but then how do we do this in the real world? And so I'll give you some examples of some patients I've seen. One is a patient who really didn't, high risk biochemical recurrence, didn't want any treatment, but he knew the tumor was growing, he needed something. So he wanted the greatest chance to get off treatment, which was combination therapy. That was the greatest chance, and would buy him the longest time off treatment. So that's what he chose. Another patient, even though he's 80 years old, he's still sexually active. And that was very, very important to him. And so we know monotherapy better preserves sexual activity. So that's the route we chose for him. So it's individual, the answer in terms of monotherapy versus combination. We do stop treatment at 9 months if they have a good response. And there's been some thought in the monotherapy arm that maybe you don't need to stop treatment because it's so well tolerated. I think we're going to have to see what that looks like long term. Certainly the trial stopped it and still had very good efficacy. So I think those are challenges we face taking this great data and now applying it to patients in the clinic.
Thank you. And the second question. Salvage radiotherapy is also an option for treatment of BCR. What is your perspective on the value of difference between radiotherapy and the novel endocrine therapy for BCR?
So the question is salvage radiation versus systemic treatment, and I don't think it's a fair question. I think if you are a candidate for salvage radiation, you should get it. Absolutely. What we know for high-risk biochemical recurrent patients is it doesn't always work. So it's not this or that, it's this, and if this fails, then that. So they're not competing with each other. They happen in sequence, salvage radiation first, and if that works, great. If that doesn't, at some point you become ready for systemic therapy, and that's when we will bring in the EMBARK regimens.
The third question. Besides PSA, what significance do PSMA PET or other biomarkers have in treatment decision-making and monitoring for BCR?
Yeah, it's a great question. I mean, EMBARK was designed in a different era when we had PSA really only, conventional imaging, and now we have PSMA imaging. We know in patients that were eligible for EMBARK that about 85% will have something on the PSMA scan. 45% of the time it's metastatic, 40% local regional. It's great data from UCLA. And so I think we take that into the context, and to me, we know for these high-risk biochemical recurrent patients, when they've had the standard pelvic radiation post-surgery, or there's radiation failures where we don't necessarily know what to do, we know enzalutamide improves outcomes. We know that. We think more radiation, some stereotactic body radiation to metastasis-directed therapy, we think that has benefits. I'm always nervous to do something I think has benefits instead of something I know has benefits. So to me, I want to do the systemic treatment. Ideally, I would add the metastasis directed, the local radiation, and maybe get greater off-treatment durations. But there's some patients that still have negative PSMA scans. 15% of patients will die from prostate cancer before the scan is positive. So we can't wait until the scan is positive because it's not always going to be positive.
Lastly, in your chemical practice, have you encountered prostate cancer patients from diverse ethnic background? Are there any significant racial difference in prostate cancer, particularly in your protest of BCR or other stage of the disease that we are discussing today?
Yeah, no, it's a great question. So in the United States, people of African descent, black patients, more likely to get prostate cancer, more likely to die from it. Asian patients tend to get less prostate cancer, tend to do a little bit better. Hispanics tend to get more prostate cancer, but actually do better. It's a little bit of a paradox. We have seen in many studies that when you apply advanced hormonal therapy to patients, the black patients tend to respond better. There's a lot of issues with race. It's correlated with socioeconomic status, access to care, having good insurance, being able to pay the doctor. So we often say that race is really a social construct. There's many social determinants of health that play in, but I think the best data we have is if you take a patient and who has prostate cancer and treat them equally, regardless of their race, whether they're Asian, black, white, Hispanic, by and large, outcomes will be pretty similar. And so that's the key, is we got to make sure we're providing good access to care. We're providing that high quality, the latest, greatest therapies we were just talking about to all of our patients.